Our next presenter is Dr. Rebecca Kruse-Jarris. And I left my cliff notes at my place. And she's our Associate Professor of Medicine and Adjunct Associate Professor of Pediatrics at the University of Washington. And she's Program Director for the Washington Center for Bleeding Disorders at Bloodworks, and definitely an educator and advocate for women and girls with blood disorders. Thank you very much.
And thanks, Sandra, for having me. This is really an honor, and this is such a wonderful colloquium, and hopefully this is going to be one of many to come. I think this is a really important group to come together. So I get to talk a little bit about factor XIII deficiency in pregnancy. Very, very rare, even without pregnancy, but certainly can happen. These are my disclosures. And this is all based on a case, and then I have a couple of data slides in between. This is a 33-year-old woman who comes to me for consultation. She's a G5P0 with several early trimester abortions, who comes for consultation. She had she had 5 early trimester spontaneous miscarriages, and then the last one she had resulted in hemorrhagic shock, and therefore she came to us to work her up for a potential bleeding disorder. Not really thinking about this before. So, of course, we take a bleeding history, and the very first thing she gives away, or that we're asking is, how was your neonatal period? And she said, yeah, I was told I needed transfusion because I had some umbilical stump bleeding, and she could have just walked in with a textbook right there. We should have known what she has. So from there, it was just, not a big mystery, but more confirming and what do we do. Further, she's talking about some easy bruising all her life. She has some self-limited epistaxis that's really just during the summer months, had menarche at age 13. Menses were lasting 5 days and were not particularly heavy, changing protection every 4 days, so nothing too unusual there. She did have bleeding with tooth extraction twice before, had a hemoperitoneum with a ruptured ovarian cyst in 2010 and needed surgery for that. Then she bled 6 weeks after a DNC for miscarriage at 6 weeks gestation. That was in February 2017. Didn't really need any transfusion with that, but certainly did have some bleeding. And then more recently, and this is why she came to me, she had this hemorrhagic shock after a DNC for a miscarriage at 11 weeks. And for that, she needed 4 units of RBCs, 2 units of cryo, 2 units of FFP, 1 unit of platelets, and an intrauterine balloon was placed. So quite significant. So we decided to work her up, and we did first things first. This is what we think this is, and we did a clot solubility test that was abnormal as expected. So that really showing us that very likely this lady has severe factor XIII deficiency. But since we're a coag workup, or do the whole workup, we also wanted to see is there something else. PT, PTT were normal. She had borderline von Willebrand factor levels with a RICO of 42, an antigen of 52, and collagen binding of 62 with normal multimers, but also has blood type O positive or type blood, so might be consistent with that. Other than that, her other clotting factors were normal, and she had full platelet aggregation studies before she even came to us, and they were also normal. So we attempted to get a factor XIII to quantify this, which is very difficult to do as it turns out, and we could confirm that it's less than 15%. But like I said before, if you have an abnormal clot solubility test, likely you have severe deficiency, and she certainly acted like it. So function of factor XIII, which is also called the fibrin stabilizing factor. Really quick to review that, and we're not going to go into details, but factor XIII is comprised of a heterodimer of A and B subunits. In the presence of thrombin, A and B subunits dissociate, and then the A units will be what is really the activated factor XIII. That then in turn while fibrin is turning into, or under the presence of thrombin, is turning into soluble fibrin polymers, they're not going to be stable. So there needs to be this cross-linking, and factor XIII will help in that to make a stable clot. Now, factor XIII deficiency or factor XIII is likely involved in wound healing. We often have people that have poor wound healing. She did not report that. It may be involved in immune function and bone formation and angiogenesis. And what we're going to be talking about, it's very important for maintaining pregnancy. So just first looking at what happens to factor XIII activity during pregnancy and normal pregnancies, and this is a study out of the UK, and that looked at that, yes, we get a little bit of a drop in our factor XIII level, but certainly not to severe levels by the third trimester, and then there's a recovery postpartum. So in our lady, our assessment is that, yes, we think she has congenital factor XIII deficiency, likely severe. What we're getting is a level less than, I'm sorry, it's 15, not 13, but it doesn't matter, but likely severe. She did have some testing before, but she's not sure that she had genetic testing done before. I'm very suspicious of an A subunit defect, and we're going to get into detail why, and definitely thought that she needed some genetic testing on that. Factor XIII deficiency is very, very rare, and here, like we've been talking about for the last, 12 hours or a day and a half, we're going outside of any or a lot of data. So a lot of what we do is just based on case reports, as we're going to see. Factor XIII deficiency is autosomally recessive, and you can have mutations in either the subunit A or B. And there are several mutations that have been described. Severe deficiency can lead to spontaneous intracranial hemorrhages. So often these patients need to be on factor XIII prophylaxis, and it gives us this umbilical stump bleeding. But what about this pregnancy loss? Factor XIII containing cells are found in the chorionic mesenchyme of the human placenta. That's been described in the 1990s. And then if you're looking at specifically the subunit A, the RNA expression, if you're looking at all kinds of different tissues, and this is impossible to see, but they looked at all kinds of different tissues, but the one up here is the placenta, so we have a particular high concentration of factor XIII A RNA expression. And it is thought that the A subunit is needed for the development of the cytotrophoplastic shell at the placental bed in early development. So looking at that practically, and what does that mean? There is very little data, but this is a really nice systemic review where they looked at the literature between 1964 and 2012, and they found 27 case reports and 12 case series and kind of put it all together for a total of 121 women with factor XIII deficiency. And they found that almost a fourth of them reported heavy menstrual bleeding, 8% had some ovulation bleeding, but now getting to pregnancy, there were 192 pregnancies described in 63 women. And in all of them, 66% or 127 women, these pregnancies resulted in miscarriages, so quite high, and only 1/3 reached viability. Now, if you're looking at pregnancies that did not receive prophylaxis, almost all of them, 91% of them, resulted in miscarriages, and very few had progression to viability stage. If you're looking at the ones where the pregnancies actually reach viable stage, 8% of them had antepartum hemorrhage of some sort, and 25% had postpartum hemorrhage. So not just how do we get them through pregnancy, but considering the postpartum period. And if we're looking at this Iranian cohort, and it seems like this is a very prevalent condition in their Iranian population, I just want to, this is the mortality data, but what I really want to look at is the red boxes, where of those women that were identified, 24 women were identified that had miscarriages, and the majority of them had repeated miscarriages. Let's look a little bit at the subunit A versus subunit B and how does that affect our obstetric or gynecologic bleeding. So on the left, you see the subunit B kind of bleeding, and on the other side, the subunit A. Menorrhagia has been described in both, maybe a little more in the subunit A. Ovulation bleeding, rare, but it has been described in the subunit A. But then here, very, very strikingly, the miscarriages that are very high percentage of 70% in patients with subunit A deficiency, less so in subunit B. And then if you're further down looking at postpartum hemorrhage, very interestingly, it seemed like, even though we're looking at very, very small numbers, but it seemed like the patients with the subunit B had more problems with that than subunit A. So back to our case, we did do the genetic testing, and they found 2 variants of unknown significance that she was homozygous for. A missense mutation and a nonsense mutation, but clearly we know that something here is significant. This lady has severe deficiency. So we said, well, she clearly needs prophylaxis. What do we do? When do we start that? What should we do? So it's quite clear and makes sense if you're thinking about how early you need this for the placenta formation, that you need to start this prophylaxis with factor XIII really as soon as possible, but certainly by week 5. And in the literature, the suggestion is that we need about a level of factor XIII level of 2 to 3%, possibly over 10%, but that is based on very little data. And then the suggestion is that by the time of labor and delivery, we get this level up to 20 to 30%. And I can tell you that also this is based on very little data. So how can we do that? We can use FFP or a cryo. That certainly is a viable option. But then we have 2 factor XIII concentrates. Here I actually did put the trade name used in the United States for recognition, but one of them is a plasma-derived one, and the other one is a recombinant subunit A containing product. Both of them are really not, there's no indication in pregnancy or recommendation in pregnancy. They are both approved for prophylactic treatment and perioperative management. And the plasma-derived has been, or alloantibodies have developed with that product. In the clinical trials with the recombinant one, we have not seen any neutralizing antibodies, but that's not to say that it can't happen. And here you have the usual doses of around 35 to 50 units per kilogram, and because of a long half-life, you can give that once a month. So the plasma-derived factor concentrate has a half-life of maybe 6.6 days, and the recombinant one slightly, but probably not significantly longer at 7.1. And again, it's thought that you do get hemostatic efficacy even in small amounts of factor XIII of about 5%. So what to do with this pregnancy? What should we dose this? And there's a very small series, again, an Iranian cohort of 17 patients where they described this regular prophylaxis in a more systemic way. They only gave 10 units per kilogram of the concentrate. This was a plasma-derived one that they had available there. Every 4 weeks before pregnancy, then once the woman became pregnant, they went to every 2 weeks. The bleeding scores with that clearly decreased from 11 to 16 to 2 to 3, statistically significant. And all of these women delivered healthy babies at 36 to 38 weeks. Now, this is not the strongest study when you read it. It's not very well done. But this is something that we have in the literature, and a lot of our recommendations are based on this. So what did we decide to do? Well, we decided what's missing here in her is clearly the subunit A, so we decided to give her, and she wanted a recombinant product, so we discussed all the options with her. And we decided to give her the subunit A product, the recombinant product. There are a couple of case reports where pregnancies were safely treated with that, and we decided to go for the prophylactic dosing of the 40 units per kilogram really for her at that point not being pregnant, but just to put her on prophylaxis to prevent any intracranial bleeding and to potentially enable that next pregnancy to stick. So she called us at 4 weeks pregnant, and she was all happy, and we increased the dose, as we had discussed with her, to every 2 weeks, and said, great, hopefully we're going to have a pregnancy this time. And then unfortunately she had a pregnancy loss at 10 weeks. Well, I don't know why that was not discovered before, but she had yeah. So she actually had a uterine abnormality and has this bicornuate uterus. So what is that? And hers is just a partial one, but it's an incomplete fusion of the Mullerian ducts. And it's the second most common reason for repeat pregnancy loss. So right here, she has a double whammy. Not only does she have the factor 13, but we also have an abnormality. Results in 28 to 35%, depending on what study you read, of pregnancy losses and premature birth. So definitely needed to throw that in the mix, and that's why it's so important that OB and hematology and everybody work together and communicate well. So what did we decide after that? Well, we put her back on her monthly prophylaxis, really more to prevent intracranial bleeding. And 5 months later, she calls because she's now 5 weeks pregnant. So we said, well, okay, let's go up on the dose again. Decided to do that. An ultrasound at 10 weeks. She has a normal heart rate, and she still has the fetus, so we're happy about that. But she's developed some vaginal spotting. So at that point, we said, let's just go ahead and see what the level is. And her factor 13 level, her trough was 15%. So we decided, because she had this spotting, to go up and give the dose weekly. With that, we achieved a trough level of 31%. And I'm happy to report she's now 28 weeks pregnant and is doing well. She has not delivered yet, but we're working very, very closely with OB to make sure that her risk for premature labor is very, very high. But we hope we're going to have a baby amongst our patients soon, and I just wanted to report that, and thank you for your attention.